Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research. And we're here to explore a wide range of topics with you through interviews with content experts.
Today, we are excited to have Dr. Megan Burgess discuss her case study that was a poster presentation at the Combined Sections meeting in 2022, titled Don't Forget the Hip, Analysis of Femoroacetabular Movement Faults in Patients with Coccydynia. My name is Nick Rainey, and we're excited to have our first AOMT podcast hosted by members of the Pelvic Health SIG. You might remember from a few months back that this was a plan to start doing this, and this is the first one. I would like to introduce my co-host, Kelli Wilson.
Hey, Nick. I'm so happy to be here and can't wait to dive into discussing about Coccydynia and the hip.
Well, me too. We are excited to bring pelvic health topics to the AOMT podcast platform and normalize the discussion. Without further ado, let me introduce our speaker today. Dr. Burgess received her doctorate of physical therapy from Washington University and is proud to be at her alma mater as an assistant professor and faculty physical therapist for pelvic health at Washington University in St. Louis, Missouri. Dr. Burgess received her orthopedic certification specialty in 2012, and she has spoken at many national conferences and published articles. And let's dive into this very important topic with Dr. Burgess.
Dr. Burgess, thank you so much for joining us. I'm really excited to have you here because I love talking about the coccyx and kind of dive in and break down the confounding presentation of Coccydynia. So I can't wait to hear what you have to say, what information and knowledge you have to share to us. But before we dive into the case, let's discuss a little bit about the background and the purpose. I know as physical therapists, we conceptualize that the coccyx is important. And when a patient comes into the clinic with coccyx pain, it kind of can lead to like a tunnel vision of isolating just solely at this main pain generator of the coccyx. And we know as physical therapists that, surgically removing the coccyx, would not be the most appropriate action, and that we can definitely help address coccyx pain. But I don't think we understand the whole big picture of the coccyx and how important it is to our anatomy, our physiology. Can you provide us some insight on why the coccyx cannot be understated in clinical practice for our patients?
Yes, hi. Happy to be here. Thanks for having me. I would be happy to talk about the coccyx and its importance. I also enjoy treating this population. And Kelli, like you said, I think it's a very understated part of the spine and part of anatomy that is very easily addressed or should be readily addressed by physical therapists. The coccyx is incredibly important, if only because of segmental interdependence. So, we know that the coccyx is an extension of the spine, and as the lumbar spine and thoracic spine move, the coccyx moves as well. So, because the spine's important, I think just by proxy, the coccyx is also important. Additionally, there's a lot of nerves that run by the coccyx. So there's some somatic nerve fibers from the lumbosacral plexus. There's some ganglion impar tissue from the sympathetic nervous system there. There is a tremendous amount of muscle attachment to the coccyx. So the gluteus maximus attaches posteriorly to the coccyx. Some lower portions of the piriformis attach to the upper part, the superior part of the coccyx. And then anteriorly, we have both the coccygeus and the puborectalis that connects to the coccyx, and also the levator plate of the levator ani. So, functionally, the coccyx is a weight-bearing joint for sitting. With the ischial tuberosities, those three items really form a nice network or bony stability for sitting, which is one reason why removing the coccyx without good cause is oftentimes not a great idea. But I think what often gets maybe the most underappreciated part of what the coccyx does is it really acts as a tether to help minimize pull of the pelvic floor. So because the pelvic floor muscles attach to the coccyx, in any position or functional movement, the coccyx kind of serves as a tether for those muscles and kind of helps be kind of a stable base for those muscles to contract and relax. So I totally agree. I think the coccyx is really understated. It's very important. It's not just a body region to be written off or to be overlooked.
Thank you for that insight, Dr. Burgess. You mentioned in your article the first line of treatment for coccyx pain provided by physical therapists is manual therapy, biofeedback, ergonomic sitting changes affecting the spine and sacrococcygeal complex, massage, TENS, and down training of the pelvic floor, which we're going to get more into that next and expanding on this topic. I believe most physical therapists hear coccyx pain, and in your experience, do you find doing internal work is necessary for all your coccyx pain patients?
So no, I think for a fair amount of patients, internal work is not necessary. It's never my go-to item that I first look at. Best practice guidelines for the coccyx suggest looking at the spine first and addressing some bigger movement things that are going on before we, directly go into the focal coccyx region. As we'll talk about with this case study, I didn't do any internal at all, and the patient had really good outcomes. So I don't think it's integral to do internal work. I think there's definitely times and places and situations where it's indicated, but it's not a end-all be-all where internal has to happen. So I think it's kind of a misconception that all coccyx patients need pelvic floor consult or referral. Definitely that's an option if there's certain situations the patient's not getting better, there's bowel and bladder issues, there's sexual dysfunction, there's other concerns that warrant internal work and consult with someone that has that training. But in general, I don't think internal work should be the primary focus of care with the coccydynia presentation.
I agree with that insight. We wanted to make sure that was one of the first things that we addressed, because it's easy for people to tune out, if you will, if that's not part of their skill set, part of their training, to make sure that everybody listening to this podcast has the skill set and the ability to address patients with this type of presentation. So thank you, Dr. Burgess.
Of course. I think, the first line, like you mentioned, all those first line interventions, that's what the research shows. I just want to point out that none of those things involve looking at hip motion. None of them involve the relationship of the hip to the coccyx, the impact that the hip can have on that region. A lot of it's movement analysis. There's not much research on it, but what is points to the spine and the lumbar spine, which makes sense. But in this case presentation, which we'll talk about, she had already had physical therapy intervention for the spine, although brief. She had had education on posture and alignment, and none of those things got better. And so I think it's natural that as movement experts, we direct our attention then to adjacent joints, to adjacent regions that can both refer, but also, again, from a segmental interdependent standpoint, impact that region, impact the region of symptoms.
Yes, I 100% agree. And that's why I appreciate this case report so much, because ultimately we learn in school, we learn in our training and our fellowship training if we're looking at someone that just has knee pain, we look at the hip, we look at the ankle, we look at the total body. And I want to halt the fear that's kind of invoked, not saying for everyone, but when you present with a coccydynia patient, that there is this immediate knee-jerk reaction like, I'm going to have to do internal and I'm not trained in that, so this is not my scope. Whereas what you're presenting was that the patient necessarily, which I want to pick apart a little bit later, but like this patient did not present with a specific coccyx injury. It was idiopathic and a repetitive micro trauma, I believe. I could be you'll discuss this a little bit more, but you were able to make gross improvement by looking, beyond the coccyx to the joint that is beside the coccyx, which is the hip. And so that's why this is so powerful and really evoking a really good conversation. So let's go ahead and let's go to the meat of the case report, which is your 14-year-old patient that presented with 6-month duration of coccyx pain, sitting for more than 1 hour and with quick sit to stands. Can you discuss your objective findings about her?
Of course, happy to. So right off the bat with her, I noticed she definitely had a propensity or a tendency to have femoral medial rotation with function. So we saw that movement pattern of hip adduction medial rotation with single leg squat, double leg squat, and sitting. So I typically start with movement and just see where my eyes are drawn, see what else I might need to check based on movement patterns. I did notice there was a pronatory foot tendency. So when she did have hip adduction medial rotation, her both of her feet, especially her rear foot and midfoot, would pronate. There was, because of that and because of her propensity for that, I did do Craig's test and found that she potentially had the anteversion. Obviously, we can't confirm that unless there's an X-ray that does, but which she hadn't had. But it just confirmed that there could be, an anteversion contributing factor that would make her more inclined to immediately rotate than, say, laterally rotate or to stay more neutral. And so what that does is it kind of helps frame my thought process. If I am going to change the medial rotation, my expectation is maybe it's not going to be perfectly neutral. Can I just minimize the medial rotation as opposed to totally kind of cure it in a sense? She had a gluteus medius strength of 3- out of 5 bilaterally, and her deep lateral rotators bilaterally, which includes the obturator internus, is 3 out of 5. We did an ODI at Oswestry disability index for her. It was 18%, so low. So she was able to do the things she was able to do, thankfully, but there was definitely room for improvement there. And her pain report on the NPRS was a 7 out of 10 on initial eval. She still had a tendency to slump in sitting, although her parent that came with her had said that it used to be way worse than it was. So she still had a propensity for that. But changing, like I said, she had interventions to help change and educate her on posture. It made no difference to her symptoms. I did not notice, this was a surprise to me, I expected almost to see a structural deviation in her coccyx, so either anteriorly or laterally, like a lateral deviation, but I did not. When I went to palpate her coccyx, I really thought we would reproduce her pain with palpation. We did not. When she moved in those movement patterns into adduction and medial rotation, she noted pain at her coccyx. So I had to do this a couple times with her. I was like, okay, so when I touch it, there's no pain, but when you move in those patterns, I had her point to where her pain was, and it was very overtly at the coccyx. Like it clearly it wasn't the buttock, it wasn't the low back. I had her with her fingertip point to where the pain was, but it wasn't reproducible with just palpation. And then I palpated the obturator internus externally. Like I said, I didn't do any internal with this patient, but externally, her obturator internus was tender upon palpation.
Dr. Burgess, you had mentioned that she could feel her coccyx pain with the hip range of motion testing. Could you expound on that, how you were able to confirm? You said you did it multiple times. Could you expound a little bit on your hip testing and what she felt and why that led you to believe that the hips were involved with the coccyx pain?
Sure. I think it was more, I did it multiple times just to make sure that I was understanding her comments and her report. I was honestly very surprised that the coccyx itself wasn't tender when I palpated it. And so I think I did it a couple times to just verify that I was getting the right information. So I watched her move. She reported she had pain. And then when I went to do a palpation testing for a coccyx, it wasn't painful. So then I was like, okay, well, let's verify that what I saw earlier was correct. I had her do squats and single leg stance again. It was painful. And again, I had her more distinctly point, show me exactly where that pain is. Show me where that discomfort is when you do that. And she pointed to the coccyx. And then I did secondary testing or symptom modification testing for those functional activities. So a double leg squat, single leg squat. And I had her decrease, or at least be mindful of how much medial rotation she was moving into. And she reported her pain decreased. So I did it multiple times, not from like a repeated movement standpoint, that I thought it needed repeated instigation to irritate it, more so just to verify that what I was seeing was truly what was happening with the patient, and not my predisposition or my thought to what should be palpably tender that wasn't.
I definitely commend you on that. We always, we think about experts doing the basics well. You expected it to be tender, as I would have as well, as with most people with Coccydynia. But what do? You do a good hip range of motion exam, asking where they feel the symptoms. You confirm that it's repeatable, and so that way you can really dive into what is the cause for her, not just what you anticipate it to be. So great job there.
Thank you. Yeah, I think as experts, I think there's a misconception that we get it all right the first time. I think there's plenty of humility that comes to being an expert and seeing a patient clientele or a type of patient often. And I think sometimes your eyes fool you, right? Sometimes you see things and you have to verify that what you saw was correct, or that the response that the patient had was consistent across trials. So
I completely agree. And I am really looking forward to more research about this, because I think anecdotally and through our clinical experience, we're seeing, applying symptom modification to these Coccydynia patients with idiopathic pain presentation by figuring out what habit are they doing. It was great. You looked at her functional movement, and to see, and, it was radiating or referring pain to the coccyx region. But looking at the patient and what they're doing, I'm thinking of a case that I had with a male that was driving a tractor and his pain was generated with his right leg to his coccyx pain, but he did not have tenderness to palpation within that region. So we worked on stabilization, strengthening around that area. So kind of looking outside beyond the coccyx is so important. So I just love this topic, and thank you so much for presenting it at the combined section meeting. So hopefully we can all work together. Anyone that would be willing to do a study, I'm sure Dr. Burgess and I would love, and Dr. Rainey, we would love to be involved. So I want to go back to your objective, with the Craig's test with the anteverted hips for the patient. And that what was interesting, like you found that she was just bilaterally weak at her obturator internus and coccygeus. And so you worked on applying or implementing strengthening exercises for her isolatory to those muscles, correct?
Yes, that's correct.
And so what's interesting, and I think Dr. Burgess, you can agree or disagree, but sometimes when we see a patient in the clinic with coccydynia, we as public health therapists, sometimes we lean more towards the muscles being in a hypertonic state. They can be weak, but they usually have overtone or overactive. And so we work on implementing stretching and lengthening exercises, getting them more aware of down training, which we'll go into that a little bit more. But with this patient, your particular patient, she was just generally weak. And so you implemented a overall strategy to increase her strength. Do you agree?
Yes, completely.
Okay. And it was funny because I was reading your case report as we were studying for this interview. And I was like, oh, that's so interesting because I have not seen in the clinic necessarily someone just being completely lax. And then I had a gentleman in my clinic the other day, and he had an idiopathic coccydynia presentation. He had been receiving pelvic floor therapy for like 3 years, but he had wavered off and had not gone for the last year. So he had continued doing not Kegels, but pelvic floor drops. That's an active eccentric lengthening contraction instead of concentrically contracting the pelvic floor muscles. He had been doing that and stretching his hip external rotators for 3 years straight. And that's all he'd been doing. And he had been told never to do concentric pelvic floor contraction ever again. Well, he had literally no tone to his buttocks. He had no activation of his deep hip external rotators. Nothing could stabilize and activate in that region. And so it made me think of you and this case study, because I was like, oh my goodness, here's someone that's completely weak, where he's taken it, not necessarily his fault, but the extreme of just never going back to strengthening the muscles when we need to bring the full picture in to these patients as well, and not just lean and swing the pendulum just one way, but pull back that picture of strengthening. Anyways, I just wanted to kind of discuss that with you a little bit and pick your brain, because it was really interesting to me that I saw that. And I 100% agree with you.
Yeah, I think you bring up two kind of great points. Or 2 points that I think really need to be stated based on that presentation. So first of all, I think we have to remember that the hips and the pelvic floor are two distinctly different muscle groups, right? We can isolate them separately. They have different innervations. They're located in different areas. They have similar muscle attachment, which is true, and they impact each other, right? There's that kind of give and take there, but they are totally separate entities. So you can strengthen one and lengthen the other, or vice versa, or potentially in some cases, maybe both need to be strengthened, or in other cases, maybe both need to be lengthened, or, there maybe needs to be focus on relaxation. So I think there's any combination thereof. It's not that every time we lengthen pelvic floor, we need to lengthen the hips as well, or decrease activation of the hips. There's plenty of opportunities or times functionally where we need our pelvic floor to be on, but we need our glutes to be off, and vice versa. There's plenty of times where we need our glutes to be on, but our pelvic floor to be off. And so there's, we have to consider that piece of it when we see patients, right? When we consider what's happening at the muscle level. Secondly, I think what's important to consider is that, sometimes for a muscle to turn on well, it has to relax well. So I think there's this misconception with pelvic health that Kegels, right? We need to strengthen. And I think there's definitely times and places where that's appropriate, but there's also plenty of, I think you ask any pelvic therapist, there are plenty of presentations and situations where down training the pelvic floor, or at the very least, just working on coordination of the pelvic floor, is more on point with what the patient needs. I often use the analogy with the patients of an elevator. If you have an elevator to a 4-story building, and as a patient, you can lift your pelvic floor to the 4th floor, but you only lower to the 2nd rather than going all the way down to the lobby, then when you lift again, if you're only down to the 2nd floor and you lift again to the 4th floor, it feels weak because you're not lifting the full excursion, but you're not weak. You're getting to that 4th, you're getting the most shortened version of the muscle, that level, but it feels weak because there's a lack of relaxation. There's a lack of range of motion of that muscle's ability to move through kind of full range of motion, if you will. And so I think that's one thing to consider, because sometimes a muscle will seem weak, but then you realize, they're not relaxing very quickly. They're not relaxing very immediately. And I'm speaking mostly for pelvic floor, but I think this is true for other muscles as well. Most of what I see in this case is pelvic floor, but I think it can be extrapolated to other regions. So for these kind of patients, though, what I was saying, it's way more advantageous to start down training first, right? Lengthening that pelvic floor so then they can get a better contraction after that, after they've worked on that, after they're able to relax fully, then they can use that full excursion that they have, use the full strength to move through the motion. So to your patient example, Kelli, I would, perhaps maybe the lengthening of the pelvic floor was appropriate, but maybe not the lengthening of the hips. Maybe, again, separating those two entities out, maybe working on relaxation of pelvic floor, but strengthening of the hip complex to support the pelvic floor, the pelvic region would have been advantageous. We know that if one body region or one muscle group doesn't do its job, another one helps out more, right? Perhaps the hips were not helping. There was too much weakness there, and the pelvic floor was then having to do more, right, to compensate for that.
Correct. And who's to say what he was presenting like 3 years ago? This is what he was presenting, this week to me. And so, yes, always maintaining an individualized approach with our patients. Of course, I know you agree, is always important, and pulling in that big picture of what is activating in the hip musculature versus, the pelvic floor muscles. And the pelvic floor muscles are easily able to, you can get a good understanding of what's going on by external palpation. And
Totally.
As a side note, what you were kind of alluding to a little bit, I think that, sometimes we focus a lot as therapists on stabilization, and if a patient presents with a forward flex coccyx, Dr. Burgess went over the anatomy of that and just understanding that the going to and leaning on giving a Kegel or a concentric contraction, thinking that would give stabilization to the coccyx would probably not be the most advantageous for that particular patient because you might be feeding into that dysfunction. I don't know if you want to expand on that a little bit more, Dr. Burgess, but...
No, I completely agree. I mean, if there's a deviation of the coccyx, whether it's laterally or anteriorly, you would really have to consider whether a Kegel's indicated, right? It could be that muscle, we know that muscles turn on to protect a lot of times, right? So if there's a deviation, or if the coccyx, because it is a joint, right? There's a sacrococcygeal joint. If it's in a position that's not ideal, then there might be muscle spasm or muscle activation to protect against that, right? To protect against further injury or irritation. So I completely agree wholeheartedly.
And one other point, because your title of your, poster was "Don't forget the hip." Let's not forget the hip in this discussion. And you're a patient that was, a younger adolescent. You're not going to be dealing with hypomobility in this population. So Working on modification was definitely appropriate. I am wondering about your clinical perspective on the older population with chronic coccydynia, or have you seen anything anecdotally that you've seen in your clinical experience pertaining to the hip and restriction and range of motion, especially thinking about unilateral deviations of the coccyx? I just wanted to pick your brain on that.
Yeah, good question. I usually, in the older patients that I see with coccydynia, it's usually not idiopathic. There was usually a fall or something that warranted a trauma or an experience that warranted the coccyx pain in the first place, versus which is a very different presentation to the case report I presented at CSM. In the older patients too, they are more likely to have potentially some limitations in hip range of motion. So I think it's even just as important in that older population that we assess that and we appreciate how the hip range of motion, especially into lateral and medial rotation, can impact the coccygeal region. It's an older study, but it's an oldie but a goodie. There was an article back in 1999 by Delp and colleagues that looked at the moment arms for some of the hip rotators, whether the hip is flexed or extended. And it was done in patients with CP, so not with coccydynia overtly. So I think that's one of the limitations of the research, is that it's not, sometimes we have to extrapolate for other patient presentations other than what the research is based on, as whether, as long as it's indicated. But anyway, what they found in this Delp article was that, this research by Delp, is that as a lot of the hip lateral rotators, as the hip flexed, they actually had more of a moment arm to become medial rotators. And even those that didn't become true medial rotators, their ability to laterally rotate decreased. So they were still maybe laterally rotators, but not as strong lateral rotators. And I think that's important and relevant to my case, maybe not to an older population, but to the case I presented of this adolescent, because her pain was mostly with hip flexion, right? So if all these lateral rotators are weak and long because she's in medial rotation, her being in flexed and being in that medial rotation position is not helping her cause, right? She is only further encouraging this natural propensity for these muscles to have more of a medial rotation moment when they're in flexion. So I hope that answered your question, but I completely agree. I think the presentation for an older patient is usually different. Not always, it doesn't have to be, but I think checking the hip and considering how the moment arms of some of these muscles change is really, really important, and really should be the standard of practice for this type of presentation, right? I think with any coccydynia, if you look at the coccydynia research, again, hip is rarely mentioned. And my point in writing this and presenting this poster at CSM was that we need to make sure we look at the hip. It is just as important as the spine and its ability to contribute to pain in the coccygeal region.
On that hip note, can you expand a little bit on your exercise prescription for the hip rotators, the external rotators, and glute medius? Want to make sure, not that our listeners can then take that directly and use the exact same prescription, but if we can get your thought process and what you did, could help our listeners if they see somebody with a similar presentation.
Yeah, happy to do so. With this patient, I really wanted initially to focus on just isolation of those muscles. So she had a hard time recognizing that she was even moving into medial rotation. So I really tried to just isolate them first. So we kind of broke them down a little bit. Worked on the lateral rotators in sitting and standing, usually until fatigue. So that's really my clinical bias. I find a lot of times if I were to pick, unless it's a muscle performance issue where a patient really can't turn on the muscle well, in that case, I might choose a particular repetition that they work towards until I know they can do many without issue. But I usually from a strengthening standpoint have the patient work until fatigue. And that was true consistently throughout all exercise prescription for this patient. But we really tried both for the glute med and the lateral rotators to focus on isolation first. And that was really just the first day. After she kind of understood how to turn them on, how to isolate them, then I really tried to push things to be more functional as soon as possible, really kind of push towards a functional position, functional movements, and ones that would better reflect when she had her pain in the first place. So as we progressed, again, I only saw her for 4 visits. As we progressed through the other visits, we got her standing quickly. I added speed variations. So we had her, even if we were isolating, had her working through quicker speed, slower speed. So she really had to challenge that muscle in very different ways. I did use resistance, both manual resistance and a TheraBand in varying positions, both weight bearing and non-weight bearing, just to challenge the muscle from a strength standpoint. We did some single leg balance items on varied surfaces and with eyes open, progressing to eyes closed so that we could really target that gluteus medius and that femoral, kind of the aberrant femoral motion that she was demonstrating. But we know that the glute med also helps keep that pelvis level and standing in single leg balance. So I really wanted to go heavy on those in the second and third visit so that she knew she could understand and appreciate the different ways that she's 14. So her limitation and her desire to understand what these muscles do was not nearly that of mine. But I felt like it was important that she understand what that muscle does so she can be mindful functionally of how to change it. And then we did also add some step up, step down, some lateral step ups on uneven surfaces, some plyometric stuff, just so she, especially the last 2 visits, so that she could appreciate how to make those same modifications, but in a more challenging environment, right? So just like we would do with an athlete, she wasn't overtly one, but she's going to be running in PE. She's going to be running with her friends on the playground. She's going to be doing things, higher level things where those movement faults might also come into play. So that's kind of the very overview as far as what we did for exercise prescription.
Thank you very much for that description, Dr. Burgess. As you know and probably can appreciate the detail of your objective examination, one of the things that you had admitted, like with the Craig test, that there's a little bit of subjectivity to that.
Completely, yeah.
There's, with that and some of the finding the pronated mid and rear foot, something that a lot of people may miss if they're going to be looking at Coccydynia. Obviously, there was also hip abduction and external rotation weakness. If somebody missed some of the findings that you found, but the person has Coccydynia, they're finding that hip rotation range of motion is affecting their pain, and they found that weakness, how much do you think that just focusing on the strength there, even if they missed some of the other objective findings, they could still have similar results if they had a similar patient?
That's a great question. I hate telling my students this answer, but it depends, right? No student likes to hear that answer. But I do think it does. I think in some cases, just strengthening the hip in this case, for example, I didn't do anything for her pronation. It minimized when we minimized her hip adduction medial rotation, but we didn't add any taping. I didn't do any orthotic placement or anything like that. So in this case, if it was this case presentation, I think just strengthening the hip would have been sufficient, right? And that's what I did, and we didn't need to do more. But I think in other cases, it may not have been enough, right? So I think as we are movement experts as PTs, that's what we do. We look at that better than anyone else, any other provider. I think it's important that we look at the whole joint. Kelli alluded to this earlier. If you're treating knee pain, you look at the hip and the ankle, right? But I think it goes more than just one adjacent joint. You have to look at the whole chain, right? So I think there's some patients where just doing the strengthening probably wouldn't have been enough. Either the patient wouldn't have gotten better, or maybe they got better temporarily, but then their pain came back, or maybe again, and maybe there's just a percentage too that would have done fine, just fine with the strengthening without any further care. But we also know too that when when pain improves, at least temporarily, patients also stop doing their home program, right? So for me, it was important that we address functional activity, because even if she's not compliant with their home program, which I try to be very sensitive to that, particularly as adolescents, right? It's a lot of times the parents encouraging them or reminding them to do home program. The more functional modifications we could make, the more likely she's likely to be adherent in the long run, right? But I didn't have to do any foot and ankle orthoses. We didn't have to do any taping. I didn't have to do any orthotic stuff. So orthotic intervention. So I think there's a time and a place for each, but I think it's important we do consider the big picture, so that if a patient's not getting better, for example, or we're not seeing the outcomes we expect to see, that we kind of know where to tackle next, where our eyes should go next, where our time and effort should move, so that we produce the best outcomes for our patients.
That was a very thoughtful answer. I appreciate that. Help other people, other physical therapists go through their thought process, which, as we know, it's the decision making in clinic that as we all get better at, our patients get better results.
Exactly. And it may be something, maybe in the initial eval, I mean, it was definitely in the back of my head from day one that, the foot's pronating, right? I might need to consider that. But just as we, as physical therapists, make movement diagnoses and consider differential diagnoses, there's always some that kind of stay in the back of your head that might emerge as you see things change with their presentation. But I think it's important, I think any expert clinician will say this, there's always these differential diagnoses kind of floating in the back of your head, ready at any moment to come forward if you see something that might support that. And for all of our more novice clinicians, I think developing that skill is so important, so that to your point, Nick, when to address the pronation, right? When that's necessary or that's indicated, because it's not always, but it's nice to know and have that kind of in the back of your head in case you need it.
Yes, thank you so much. I 100% agree. And I think that you have brought to light a very important discussion, not just with the coccyx, but, expanding the whole picture here. And I hope that we have helped our listeners with some pearls and takeaways from this episode today. I'd like to thank you, Dr. Burgess, for being here with us and having this talk. And
Thank you so much for having me. I appreciate being here.
I as well would like to thank everyone for being here discussing this coccyx and hip case. I hope it's very insightful for our listeners, and at some point they'll be having a patient and they will remember this, just as Kelli did earlier, just not too long ago after reviewing this case, and she recognized it in her own patient. I hope that our listeners recognize pearls from this in their patients very soon.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.